Hello, my name is John Tsai from the UCI School of Medicine. In this video, we will be discussing hormones produced by the kidneys, hormones that regulate kidney function, and hormones that are affected by renal function and dysfunction. The kidneys are actually one of the larger endocrine organs in our body, and as you've already seen in our previous videos, hormones play a very important role in regulation of our electrolytes. We will continue our discussion today on some of the other effects that these hormones have in our body. So far in our videos, we have actually talked a lot about hormones. If you recall, we talked about the role of antidiuretic hormone in water and salt regulation in the first video. We then talked about the role of aldosterone in potassium regulation in the second video. In the third video, we also discussed how aldosterone plays an important role in acid regulation in our body. And finally, in this video, we will talk about some other hormonal effects on and by the kidney. These are the major hormones that are produced or have some effect on or through the kidney. These hormones feature very commonly in everyday clinical practice because they also have far-reaching consequences outside of nephrology. Let's take the renin-angiotensin-aldosterone system, or RAAS, for example. While the kidneys are the primary ignition point for regulation of this system, as we'll see, the lungs, liver, and blood vessels all have some role to play in the regulation of this entire system that is integral to regulating our blood pressure, blood volume, sodium, and potassium levels in our body. When we have too much fluid in our body, the natriuretic peptides become activated while the RAAS system becomes inactivated. The kidneys are also important at calcium homeostasis via vitamin D metabolism, as we will see in this video. And lastly, our kidneys are also important at making the hormone erythropoietin that is essential for producing red blood cells in our body. We will continue to discuss each of these hormonal systems in more detail in the slides ahead. Let's go back to the renin-angiotensin-aldosterone system and take a closer look at all the moving parts. You will no doubt have already learned about this pathway in your other blocks, so hopefully this will be a review. Let's start on the left-hand side. The kidneys are responsible at sensing any changes to blood volume, and they do this primarily through sensing renal perfusion and sodium delivery in the juxtaglomerular apparatus, or JGA. In response to a decrease in blood volume, the hormone renin is produced. Renin is then responsible for helping convert angiotensinogen that is produced by the liver to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 primarily in the lungs by the angiotensin-converting enzyme, or ACE. Angiotensin 2 then has multiple pleiotropic effects throughout the body, including increasing sympathetic activity and increasing arteriolar vasoconstriction, which will result in an increase in blood pressure. Angiotensin 2 is also responsible for stimulating the adrenal cortex and producing aldosterone, which will also increase sodium reabsorption in the distal tubule, as we had discussed in previous videos. In addition, angiotensin 2 can also help stimulate production of antidiuretic hormone, or ADH, that will also stimulate reabsorption of water. All of these effects make sense in the setting of decreased effective arterial blood volume. This hormone cascade triggers an increase in blood pressure and stimulates the body to reabsorb as much water and salt as possible to increase the effective circulating volume so that perfusion to the juxtaglomerular apparatus improves and hopefully will then decrease the production of renin. As you can expect, once our blood volume is replete, renin production ceases with a concomitant decrease in aldosterone and ADH levels that then result in more sodium and water wasting from the body, especially in times of volume excess. This system is a very important system for you to know, not only because it has many effects throughout the body, but because there are so many medications that target almost all of the items in this pathway. Since this pathway deals a lot with blood pressure, you can imagine that any blockage of this pathway with medications will result in a decrease in blood pressure, and this is primarily the activity of these medications. We have already talked about some medications that block the aldosterone receptor and the antidiuretic hormone receptor, but there are also direct renin inhibitors, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers. Knowing this system will help with understanding how these medications we use to block this system to have their intended effects, but also help to understand the primary effects that these medications can have. Let's take a closer look at where renin is produced in the kidney. The macula densa cells sit at the end of the thick ascending loop of the loop of Henle and and it is responsible for sensing sodium concentration. In response to higher or lower sodium concentration levels, this triggers a cascade of events that leads to production of renin. In states of low sodium concentration, for example, when we are volume depleted and there's not much sodium left in our filtrate after being reabsorbed in the proximal tubule and the loop of Henle, this will trigger the maculodental cells to activate the pathway leading to renin production by the juxtaglomerular cells located in the afferent arteriole. This ultimately leads to activation of the RAAS pathway to additionally conserve sodium in water through the mechanisms we outlined in the previous slide. When sodium concentration is high and we are volume replete, then this decreases renin production and allows vasodilation and lower reabsorption of sodium and water. Another important hormone that has some effects of maintaining volume in our body is the natriuretic peptides. Natri refers to salt, and uretic refers to in the urine. So you can imagine that these hormones have some effect that results in more salt in the urine. While the RAAS system deals with low volume, the natriuretic peptides deal primarily with high volume states and are produced when our body sends too much fluid in our body. Atrial natriuretic peptide, or ANP, is produced in the cardiac atria as a response to stretch receptors. When there is an increased venous return to the heart, the atria are stretched, leading to production of the atrial natriuretic peptide, or ANP. This results in peripheral vasodilation to help decrease blood pressure and also nudges the kidney to excrete more sodium to get rid of that extra volume. It does this by increasing glomerular filtration rate and decreasing renin and aldosterone production. Similarly, brain natriuretic peptide, or BNP, is also produced in states of high volume through stretch receptors in the brain. With high volume, an increase in BNP is produced, which leads to similar activity as ANP and results in increasing urinary volume, vasodilation in the peripheral vasculature, and of course, increasing sodium wasting, hence the natriuretic property of BNP. We clinically use BNP as a lab test to help us determine if a patient is volume overloaded or not, especially in complicated cases of heart failure. While it is not the best marker for volume status, elevated BNP levels can suggest high volume status and can prompt us to use diuretics to help our body get rid of more water quickly to improve the volume status of patients. Let's pivot away from hormones that relate to volume and talk about calcium metabolism. One usually doesn't think of nephrology as being related to calcium metabolism, and perhaps our endocrinology colleagues would concur, but the kidneys are actually important players in the vitamin D metabolism that makes nephrologists integral in helping manage bone health, especially in patients with chronic kidney disease. The primary renal importance of calcium metabolism lies in the conversion of inactive 25-hydroxyvitamin D to the active 1,25-dihydroxyvitamin D. This is the last step in activation of vitamin D, but is crucial to allowing vitamin D to have its intended effects on the bone and the gut. At the beginning of its life, vitamin D is either ingested as a supplement or produced naturally in the skin after exposure to UV light. This forms the first form of inactive vitamin D. The liver is then responsible for hydroxylation of vitamin D to 25-hydroxyvitamin D. And finally, through the activity of the 1-alpha-hydroxylase enzyme, the 25-hydroxyvitamin D is converted to active 1,25-dihydroxyvitamin D. It is only this form of vitamin D that results in calcium absorption from the gut and calcium regulation through effects on the bone that lead to calcium absorption. This active vitamin D also leads to improvement in bone health over time. Let's see how this works in the hormonal cascade. Let's say that our serum calcium levels are low. This leads to an increase in parathyroid hormone levels that do two important things. First, PTH increases conversion of 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D. Second, PTH can directly act on the bone to increase calcium release of the bone. The active form of vitamin D then goes to the gut to increase reabsorption of calcium into the bloodstream to bring our serum calcium levels back up to normal. You can imagine that if you either have liver or kidney failure, the entire vitamin D pathway is broken, and this is entirely true. patients with kidney failure cannot produce active forms of vitamin D, which ultimately result in low calcium levels in the body. The low calcium levels then stimulate high parathyroid hormone production. But because there is no kidney function to convert inactive to active vitamin D, the high PTH levels persist, and the pattern we typically see in chronic kidney disease is low calcium and high PTH levels due to what is known as secondary hyperparathyroidism. I'm also including a great paper from 2010 here that can be used as an additional resource if you want to know more about vitamin D and calcium metabolism. It goes into a lot of the studies done on vitamin D, which is not necessary for you to know now, but may be an interesting read nonetheless. Lastly, let's talk about another important hormone produced by the kidneys called erythropoietin. Erythropoietin is responsible for increasing red blood cell production in the bone marrow and is usually produced in response to low oxygen levels sensed by the kidney. The discovery of this pathophysiological mechanism is incredibly interesting, and the discoverers of this pathway received the Nobel Prize in Medicine in 2019 after decades of research into this pathway by William Kaelin, Greg Samanza, and Peter Radcliffe. Briefly, anemia leads to a decrease in oxygenation in the kidney, and there are transcription factors called hypoxia-inducible factors, or HIF, that respond to low oxygen levels to result in an increase in erythropoietin production by attachment to the hypoxia response element, or HRE. Erythropoietin, or EPO, then goes to the bone marrow to induce production of red blood cells in an attempt to increase oxygen levels in the body. Once oxygen levels in the body improve, this decreases the production of EPO to a lower level to maintain a normal hemoglobin level. Of course, there are other variables that are involved with red blood cell production, including the presence of iron and other factors responsible for maturation of red blood cells. The top part of this figure shows how in the presence of normoxia, or normal oxygen levels, HIF is broken down through a series of processes that involve conjugation to the von Hippel-Lindau protein, ubiquitination, and proteasomal degradation that prevents activation of the HRE. The details here are not necessary to memorize, but know that we do have medications that target this pathway to improve erythropoiesis in the body. Now, as you know, the future of medicine is in AI. Well, maybe not, but AI actually poses a potentially interesting way to learn medicine. There are some limitations to AI, especially with cutting-edge research, since most of the AI models have not accounted for any information from the internet since about 2021. But it's actually pretty good at providing information that is relatively well established. If you have a chance, you can sign up for a ChatGPT or Google Bard AI account. They're both very similar in nature. Give it a prompt like, provide an overview of how the kidneys regulate erythropoiesis, and then see the response. If you want further in-depth information, prompt it to give you more details on a specific area. Before you believe everything you see and think it's the greatest thing in the world, just be aware that these AI chatbots are a statistically based algorithm programmed to provide you with the highest statistically relevant information, regardless of the accuracy of the information it provides. Or some may say it can provide facts, and it can provide alternate facts. While AI is a great tool, I would just be cautious about believing everything you learn from ChatGPT or any AI statistical model. I've seen it give false information before, even though the AI algorithm will state it with such resolve. I'll finish off with a question to solidify your knowledge. The medications lisinopril and benazepril are two very commonly used blood pressure medications. They're in the class of medications called ACE inhibitors. As you may have guessed, they work by blocking the angiotensin converting enzyme in the lungs and decrease conversion of angiotensin 1 to angiotensin 2. This can have effects later down in the cascade, and one very important side effect that clinicians must remember is having to do with potassium levels. Now, knowing the pathway of the renin-angiotensin-aldosterone system, can you predict what the effect will be on potassium levels in the body after using lisinopril or benazepril? Pause the video here to think about the pathway and come up with your answer of how these medications would affect potassium levels. When you're ready for your answer, click play again. To answer this question, let's trace back to what happens when we block the conversion of angiotensin 1 to angiotensin 2. This decreases the angiotensin II levels, leading to a decrease in its effect that angiotensin II has, including on sympathetic activity, arterial or vasoconstriction, and sodium reabsorption through the production of aldosterone. In addition, the angiotensin II decrease will affect the water reabsorption through affecting the production of ADH. Remember that potassium regulation is primarily affected by aldosterone levels, and if we aren't producing aldosterone anymore due to an upstream blockade in the hormonal pathway, this results in a lower activity of aldosterone. Recall also that aldosterone leads to sodium reabsorption through the ENaC, but also potassium excretion through the ROMK channel to maintain electroneutrality. If we aren't able to reabsorb sodium, then we aren't able to get rid of potassium, which ultimately results in high potassium levels in the body. Hence, one of the major side effects to using lisinopril or benazepril or any ACE inhibitors or medications that inhibit any of this pathway is hyperkalemia. Thank you again for joining me in today's video. Let's recall that we talked about the renin-angiotensin-aldosterone system, or the RAAS system, and how it regulates blood pressure, water, and sodium reabsorption in states of low effective arterial blood volume. We then talked about the other side of the spectrum with the production of atrial and brain natriuretic peptides in the setting of high blood volume. And we then had a brief discussion on calcium vitamin D homeostasis, as well as how our kidneys help us regulate erythropoiesis. I hope you all have a better understanding and appreciation of how the kidney works, especially its interaction with other organs and parts of the body to maintain the homeostasis we need to continue living long and healthy lives.